right. Good evening, everybody. Thank you for attending tonight's webinar brought to you by brightbod.com. I'm Kelly. I'm a 10-year breast cancer patient and a 3-year metastatic breast cancer patient. And as a patient, not doctor, so please do not construe what I say tonight as medical advice. I certainly don't have those credentials, although I have been through quite a bit. So hopefully you'll learn a little bit as we go through the details tonight. If you're not watching live, don't worry. You can still interact with this webinar by going onto brightbod.com and asking a question, recording yourself asking a question, and then we'll get out there and we'll answer it for you. So please, do know that you can still take part in the webinar even in that way. As typical, we're going to do about a 20-minute presentation, and then we're going to be answering your questions afterwards. Again, your questions are my favorite part, so please take notes and ask questions, as many as you have after the presentation's been over. I'm going to go mute everybody's microphone while we get started, and we'll get the webinar up in just a second. All right, so tonight's topic is about choosing the right type of breast surgery after you've been diagnosed with breast cancer. There's a whole lot to consider and a lot of things people overlook or are not told by their breast surgeon or oncologist. So I really want to take you guys through some of the decision-making processes and how you make the best decision for your particular situation. So you had a biopsy that confirms you were dealing with breast cancer. And this works for both male and female. It's not just a female situation. Men get diagnosed with breast cancer every single day. Typically, you're dealing with a fine needle biopsy where a needle is inserted into the tumor, and that under a microscope confirms you're dealing with breast cancer. So then you're faced with a decision about what type of surgery do I have? Do I go with the double mastectomy? Do I take a more aggressive route in that respect? Or do I go with a lumpectomy, which is just removing the lump, and then going with some additional radiation in that respect? So a lot of things to consider in that space. Among the first things to do, appropriate for staging, is to request a PET scan. I can't tell you how many people I know that have had early stage breast cancer diagnosed because there's a small tumor in their breast. And come to find out months later, after they had some severe back pain, they actually were dealing with metastatic breast cancer that had spread from the breast to distant organs, in this case bone. So one of the most critical things to do from a staging perspective, and we'll get to this in a minute, but also in determining the type of surgery that you need, or if you need surgery, is getting that PET scan. So that will tell you if you're a candidate for surgery or if you need to approach it from a different route, quality of life versus curative intent. Something else that's really important as you look at your treatment options and your surgery options is what's called an Oncotype score. And an Oncotype score is really based on your tumor pathology, and it determines this is how likely your cancer is to respond to chemo. So a certain score in that would say, okay, you're a good candidate for chemotherapy, you may want to delay the surgery, or you're a poor candidate for chemotherapy, we need to look at a different hormonal option or something of that nature. So Oncotype score is pretty typical nowadays. It wasn't so much when I was first diagnosed, it was just kind of coming to the forefront. But right now it's something that you should get consistently, so do ask your oncologist if they don't bring it up. Another thing that's super important is the pathology report. It's going to include things like, what is the grade of my cancer? Not stage, grade. It's on a scale from 1 to 3, and it determines how fast is my cancer dividing. So how quickly do I need to make a decision? Is it likely to come back again in the same breast tissue if I decide on a less aggressive breast conserving operation? So pathology is really going to indicate for us if you're dealing with the estrogen receptor positive breast cancer, estrogen receptor negative breast cancer, HER2 positive, which is a human growth protein. About 20% of breast cancers overexpress that protein, so there tend to be a lot more aggressive and a different treatment round that we would go through in that respect as well. And among the last things to think about is, where's the tumor located? If the breast cancer is behind the nipple, for example, you can't keep the nipple. This was the thing that first shocked me about my own diagnosis. I was mortified that I would lose my nipple. I couldn't fathom what I would do with a tattooed on nipple. It just blew my mind. Eventually, I got used to that idea and decided on double mastectomy. But at first, or as a 26-year-old, it was something that I just couldn't comprehend. So if a tumor is close to your chest wall, for example, You're not going to be able to get a lumpectomy because you'd have to remove so much tissue around that to get clean margins. And margins are really just a circumference of non-cancerous tissue around a tumor. So if people think that they got it all, indicates that there's not going to be any sort of recurrence. That's not true. If you've watched my webinars for a while, you know that. But it is something that doctors try to get just to make sure that they've removed all remnants of the tumor, if not at a microscopic level. Among the most important thing to remember as you go through this type of procedure and this horrible news is you have time. You have time to make a decision. You don't have to get it out tomorrow. You don't have to get it out next week. It has been growing for a long time to get to a point where it's actually palpable or able to be felt. In my case, the tumor was growing for 10 years before it was the size of a peanut, so 1.7 centimeters, large enough for me to feel. So although the sense of urgency is certainly something I felt, I knew with some research that I did, it had taken a long time to get to that size. So I wanted to really take a step back and reflect on making the right decision, and just know that you don't have to make a decision right away. All right. So now that you have all the information from your doctor, you talked about the pathology report, you got on the Oncotype score, how are you going to use what you've learned to make an informed decision on the breast cancer surgery? And we talked about this a minute ago. The stage is super important when you're dealing with whether to do surgery or not. And here's why. If you have advanced breast cancer, like about 10% of patients are when they're diagnosed. So about 10% of people are diagnosed with what's called de novo, which means at presentation, they are stage 4. Taking the breast off or taking the tumor out is kind of pointless. It doesn't impact overall survivability. The horse is already out of the barn. So most doctors today won't even do breast surgery on people that present de novo. My friend Lisa was diagnosed de novo, and she did eventually fight for a mastectomy, because think about knowing that you have terminal breast cancer and being able to feel that tumor in your breast on a daily basis, and just knowing that your life is going to be taken because of that thing that's in your breast that you can feel and you're very much aware of. So as a quality of life issue, it's something we definitely push for in the breast cancer community, but many doctors won't do it because you can't risk the infection risk and just delaying treatment overall in the metastatic setting. Breast surgery is available for pretty much every other stage except for stage 4. So 0, 1, 2, and 3. The Oncotype score, I mentioned that earlier, less than 21 means you're less likely to have chemo. You can still get breast surgery, and will probably still be encouraged to get breast surgery, but you don't have the chemotherapy before or after decision to make. So that certainly makes that decision a little bit easier. A chemo or Oncotype that's higher than 21 is something that you would definitely want to get chemotherapy, and then we'll get more into the adjuvant, neoadjuvant conversation on the next slides. The grade, I see that I left a piece off my slide. I'll just talk you through it. The grade is something we talked about earlier. So an indolent cancer is going to be graded at grade 1, and that's going to be a slower growing cancer. Typically in older people, the cancer is a little bit slower growing. Moderate cancer is going to be graded 2, and it's pretty much what it sounds like. It's not quite as aggressive as grade 3, and not nearly as slow growing as grade 1. So typically middle-aged people are going to experience that particular cancer grade. Grade 3, which is what my cancer was graded at, and in most cases young women do have grade 3 cancer, is the most aggressive. It is the most different looking from the primary breast cell that this cancer formed from. So most aggressive, fastest growing, even for my slower growing cancer overall, and definitely something you want to make a semi-fast decision on when it comes to what surgery you want to go for. The location of the tumor, you mentioned this earlier. Near the chest wall, we're going to have less likelihood of clean margins for the lumpectomy space. Mastectomy will probably be recommended for chest wall recurrences. And then behind the nipple, you're going to lose that nipple. Cancer cells have a tendency to hide behind the nipple, so they are rarely doing nipple sparing mastectomies anymore because of that fact. People tend to believe that having your breast removed means that you're not going to have a recurrence. Get all the breast tissue out and I'm going to be golden. And it's just not true. There's The cancer can obviously spread through the blood vessels and the blood as well as the lymph system. So the overall survivability of breast cancer doesn't differ between the mastectomy crowd and the lumpectomy plus radiation crowd. So do consider that as you're thinking about what kind of breast surgery to go through as well. All right, so you decided on the surgery to do. Do I begin treatment before or after my surgery? And there's a lot of things to consider when you ponder that. Most people want that tumor gone. They don't want it. They don't want it in their body anymore. It's something they can feel. In some cases, they can see. They want it gone. So most people try to opt for having the operation before they begin treatment. And I caution people on that. There's a couple of things that we want to consider when dealing with what we call adjuvant and neoadjuvant therapy. So just to define that real quick, adjuvant therapy is essentially treatment after surgery. So whether you're going through chemo or going through a hormone therapy regimen, this is getting surgery first and then going through and getting the treatment afterwards. So they tend to recommend surgery first on low to mid-grade tumors, smaller tumors, where they're not going to be taking out a ton of tissue to get those clean margins, and the estrogen-fed cancers that are HER2 negative. So these are going to be, for the most part, the lower grade tumors and the tumors that are less aggressive and less likely to come back in the same breast space, in the same breast tissue as it was removed from. Neoadjuvant therapy is just what it sounds like. It's treatment before surgery. And this is going to be associated with a higher grade tumor and larger tumors and HER2 positive tumors. So why would you want to leave a breast tumor in your breast when you're going through treatment? Well, this is really your only indication that your treatment is working. As that tumor becomes smaller and is less active metabolically on a PET scan, you have a good indication that your treatment is working and it's something that you should continue to take. When you have surgery before treatment, you don't really know if the medication is working as you would expect it to. That was what we did in my situation. We took it out and we didn't fully know if the chemotherapy that I was on was working for me. So although it kind of goes against the laws of reasonability when people just want to get that tumor taken out, there really is a lot of benefit to leaving the tumor in, gauging a response, in some cases changing the treatment, and then making a decision to do the surgery after that cancer has shrunk, in some cases has gone away completely, based on that treatment regimen. I have a friend in Philly who is going through treatment right now, and she was on chemotherapy, left the tumor in her breast. The tumor actually grew on chemotherapy. It was very unexpected by the doctors, but it told them that this chemotherapy is not working, we need to try something different. And something different was also in that they got the pathology wrong. So they didn't do a minute enough test to determine if she was actually HER2 positive. There's 2 tests for HER2 positivity, one being the FISH test. The second is a lot more detailed, and it looks at a greater detail within the cells. They found that they missed that she was HER2 positive and was actually a great candidate and needed a drug called Herceptin. And Herceptin is a drug that's going to go after those HER2 positive tumors. So switch medications and the tumor is starting to shrink. But if she would have had that breast removed and the tumor removed with it before she started treatment, she would not have known that she had the pathology wrong, and that could have, it could have led to her demise. So we definitely want to pause and try to figure out what the best option is, treatment before or treatment after surgery. So what do I need to know about reconstruction? Reconstruction is something you hear a lot about in the media. More and more nowadays, people are even opting to get no reconstruction and deciding simply to either use a prosthesis or just go bare flat chested. There's an entire movement called flat topper pride that's all about not being defined by your breasts and not worrying about getting the reconstruction. Reconstruction is a painful process. I went through it. It took about 7 or 8 months to get to where I am now. Never dreamed that it would take all this pain and multiple surgeries to get a normal looking breast mound in a bra. So things that people need to consider are you're going to be dealing with surgical drains And if you've never seen that before, there's a picture of it right there beside surgical drains. They look like little hand grenades with blood inside of them. It's pretty foul. But really, these drains just snake through your body and pull off that excess fluid, the serous fluid that's building up during the healing process. And you can have as many as 4 during this process, and they can last for a month. I had a drain in my armpit at one point for a month. It's pretty gross, and it makes it difficult to take a shower, difficult to really dress normally, because you have to have something that'll allow you to hang those drains from, or a pocket on the inside of your outfit so that they don't fall and hang down. They're actually stitched to a place in your body so that they would tug on that if that were the case. People have these unrealistic expectations about what is the mastectomy going to look like? Is it going to be scar-free? Is it going to look like my normal breast? The answer is no. You're going to have visible scarring. It's going to last for a while. Just in the past couple of years, my really, really red scars have started to fade to a medium pink. So we certainly will always retain the scars from the surgeries that we've had. Something people don't really understand is that when they have the breast tissue removed, they're also taking nerve tissue with it. So you're not going to be able to feel your breasts in most cases. You're gonna not be able to keep those breasts warm either. If you're dealing with a mastectomy, your breasts are going to be a couple of degrees cooler than the rest of your body, which is a little odd to get used to. And it'll feel really strange in clothing as well as you get used to this new body. But do expect a loss of sensation. That's something that nearly everybody experiences as they go through mastectomy. Realistic expectations is really important. People sometimes go in and say, "This is my free boob job. This is what I've set out to do," and they'll be really disappointed when their breast doesn't look perfect as they expected it to. You're removing a lot of tissue. You're removing a lot of skin. So in some cases, you have kind of a football-shaped breast that is left after the skin-sparing mastectomy. It's not going to be the typical breast shape. You're not going to have the projection that most people with a normal breast possess with a reconstructed breast. The goal is to get it to look symmetrical and normal in a bra, not naked, in a bra. So that's hard for a lot of people to accept, and it certainly was for me early on. Something to be aware of is there's an act called the Women's Health and Cancer Right Act of 1998 that actually says if you have breast cancer, you are constitutionally guaranteed to get surgery that'll actually generate symmetry for both of your breasts. So you have coverage for reconstruction, you have coverage for the other breast. If you have one breast removed and then reconstructed, you have coverage to get that breast, the other breast, the healthy breast, to look as normal or as close to the other breast as possible. So, if you get pushback from doctors that say we can't do this, we don't have to do this, yes, they do. And there's legislation that makes that fact. All right. So which kind of reconstruction is right for me? Well, there's a lot of, it really depends on what kind of surgery you have. And within that, there's a lot of different options that you have based on your individual needs, and in some cases based on your breast size, because it's really difficult to reconstruct a large breast, a C or D breast, with the typical implant process. So they typically use what we call analogous tissue, which we'll get to in just a minute. So with a lumpectomy, we're dealing with a lumpectomy defect, and I had this as well. So my biopsy was actually an excisional biopsy, and we took the entire tumor out of my breast rather than do a fine needle biopsy. So I was left with a divot of about the size of a silver dollar, something like that, in my breast. And I didn't stop there, obviously. But if that is where people stop, in many cases that it is, they can get fat grafting in different places in their body, the buttocks, inner thigh. They can also get a very small implant inserted, depending on how much tissue they removed. For a very large tumor, it could certainly be a good decision to put a 50 cc or 100 cc implant in, just to allow symmetry with the other breast that remains. They can also do something called tissue expanding, and this is something that I went through. Essentially, they're placing an empty saline holding bag under your muscle. So they pry the muscle off your rib cage, and then they put these little ports at your side. So there's little tubes that go down your side and are under the skin. So they inject saline over a 6 to 7 month period, which basically creates a pocket for the implant to live. So you are being expanded not just in the skin section, but also your muscle is being expanded to allow that layer of softness to exist between the implant and your skin. Because there's no breast tissue left, there's no fat. So you would just be essentially be able to see the implant, the rippling, the unnatural appearance of an implant under the skin. So they typically put the implant under the skin and do so with the tissue expansion process. Mentioned breast lift and reduction for the symmetrical piece of it. That's something that they typically do with lumpectomies as well. Mastectomies, you can either do 1 or 2. Most young women decide to get 2 with the belief that they're not going to have recurrence. Older women tend to go for lumpectomies or don't get reconstruction. It's certainly a generational thing. Analogous tissue, we're dealing with tram flap, DIE flap, and a latinimus dorsi flap, which is really tunneling existing muscles from your body to that place in the breast to reconstruct the breast. So stomach, mid-thigh, and this muscle back here, the lat flap surgery to move that around. And this actually does have sensation in some cases because they do microsurgery to connect those nerves. And in some cases, it actually is a warm, natural feeling breast because of that, but you do have more scarring. Nipple reconstruction is something that they also do nowadays. And the easiest kind is the 3D tattooing, which is what I have. They also have a type of operation where they take a 4-point star and gather it up from your skin on your breast and then form it into a nipple mound. Then you have permanent THO, I guess. It's not the best option for me. And then they tattoo around that to give a natural look of the areola. They also, in some cases, have taken the nipple off and stored it temporarily on your stomach, which I think is a little terrifying, and then relocating it once the surgery and chemotherapy is over. But that's not something they do much anymore because the breast cancer cell's ability to hide inside the nipple. And we talked about the star flap and escape flap. Yep. In some cases, like we said earlier, some people choose for no reconstruction. There's some really fantastic tattoos that I've seen over those flat scars that really represent a person's personal decision about how or if they reconstruct their breast. The breast band is completely removed. It's perfectly flat. It's actually a beautiful thing. I have a number of friends who have decided not to do that and have chosen some really amazing tattoos instead. So, very personal decision. Hopefully this gave you guys some additional information to think about as you undergo your breast cancer journey. All right. Any questions for me?
Yes, Kelly. Go ahead.
Kelly, you mentioned earlier, if you're diagnosed with stage 4 breast cancer, it's not recommended that you do breast surgery. Is that it?
Right. That's right. Yeah, removing the breast is not going to increase your survival time frame. It has not been shown to improve the overall prognosis. So when you're talking about a mastectomy, for example, you're dealing with about a 3 to 4 week recovery time frame. During this time frame, you cannot be on chemo, you cannot be on targeted therapy. They don't even really want you to be on hormonal therapy because it does impact your ability to heal. So essentially, you'd be delaying your treatment by a month or more. If you have complications, it could be a lot longer. Just to get that breast gone because of what it reminded you of. More and more younger women are really pushing and finding a doctor that'll do it because it is a quality of life issue. But so many doctors will just say, the horse is out of the barn. We're not going to do surgery because it's not going to help you live any longer.
Okay, thank you.
Mm-hmm. Great question.
Kelly, could you explain a little bit more about the act as far as, does it affect the insurance? Is it an insurance issue or is it available? Can you explain a little bit more about that?
Absolutely. So right now it is based solely on people that have insurance. And it's dealing with the fact that you have insurance to get your breast removed. This insurance must also pay to reconstruct the breast and the other breast to look symmetrical to it, as well as deal with any sort of side effects like lymphedema that may arise out of having your lymph nodes removed under your armpit. So at this point, it's dealing strictly with insurance. These things may be changing as we, as many of us lose insurance, or as the insurance world changes with what's being discussed right now in the House of Representatives and the Senate. So yeah, for right now though, it deals with insurance, and they must pay if they pay for the breast to be removed.
Okay, thank you.
Thank you.
Kelly,
Mm-hmm.
I got on a little late. I had a little bit of computer issue, so I'm not quite sure how deep you got into the Oncotype score. Exactly, what is that score? How is that put together?
So the Oncotype score is based off of tumor tissue, and they do a number of tests with it to determine, is this cancer going to be receptive to chemo? People automatically assume that all breast cancer is susceptible to chemo and that we're all going to respond to it. The fact is, breast cancer is not always a quickly growing cancer. Chemotherapy doesn't go after breast cancer cells. Chemotherapy goes after cells that are quickly dividing. So that's why you lose your hair. That's why you have mouth sores. That's why you have female issues when you're going through chemotherapy. Some breast cancer cells just aren't dividing quickly enough to even be recognized as an issue by chemotherapy. So people are often overtreated from a chemotherapy perspective. I believe that I was. I don't think I got much of a benefit from chemotherapy given how slow my cancer was growing. So the Oncotype score just really says this cancer is not growing fast enough to get a benefit from chemotherapy. You're better off sticking some hormone therapy instead.
Okay, and then you said the numbers. So you said less than 21 means you're unlikely to have chemo?
Unlikely to benefit from chemo.
Benefit from, okay.
Yeah. Unlikely to get a good benefit from it. Now, some people still decide to do it because they want to do, the scorched earth policy, and I'm going to do everything I can to live. And that's certainly up to them, and their oncologist probably won't try to talk them out of it. But some people really just spend 5-6 months going through grueling chemotherapy to not have much of a benefit for it. When I went through my second recurrence, stage 3, in 2013, I had chemotherapy, and my scans were identical pre-chemo and after chemo. So essentially I got zero benefit from it, and within 9 months I progressed to stage 4. So I spent 3 months of hell, going through chemotherapy again, losing my hair, being sick as a dog, to no avail. So it certainly was not the right decision for me. For many it is, but the Oncotype score is helping people make that decision with better information.
Okay, thank you.
Thank you.
Okay, Kelly, and I had a question regarding the Oncotype score too. I think you pretty much explained it, but it's basically has to do with the type of cancer, not necessarily with the constitution of the individual or anything like that, right? In terms of whether they're a good candidate for chemo.
It does actually. So they're taking tumor samples from an individual, and they're testing it with a number of different assays to determine if this particular cancer is going to respond to chemotherapy. The problem with that is that tumors are not heterogenic, which means that you could take a tumor cell from this side of the tumor and a tumor cell from the other side of the tumor. Not only may you get a different growth rate, you might even get a different flavor of breast cancer. You may get one side that has triple negative cells that don't have estrogen receptors or HER2 receptors, and one side that has estrogen receptors and HER2 receptors. So that's among the toughest things about breast cancer, is that a single tumor doesn't have the exact complete composition as you would expect. So we're really encouraging oncologists to take more samples and test 3 or 4 different areas of the tumor, rather than just saying this one area is going to tell us if we're going to do chemo or not. But in general, this test does allow people to make the decision of their own situation. Is chemo going to be a good option for this person?
Okay, thank you.
Thank you.
All right, one more question. I heard on the radio today that the American Cancer Society released new breast cancer guidelines. Had you seen or heard anything about that?
I think it has something to do with mammography and the age of which you're supposed to get treatment or supposed to get mammograms. I heard about it. I think it also has to do with there not really being a whole lot of benefit to having mammograms, and sort of a mea culpa, if you will, of the past 4 decades of how they told people to protect themselves with early detection and that kind of thing. So I believe that's what it's talking about. If I'm wrong, I will come back and I'll address it on next week's webinar.
All right, thank you.
Thank you.
Do a lot of people who have to undergo reconstruction surgery, do they also maybe have to do counseling or something to help them kind of cope with the fact that they're, basically changing their anatomy and that sort of thing?
That is a huge, huge point. Absolutely. As your body is adjusting, not just through reconstruction, but also post-mastectomy while you get ready for reconstruction, there are tremendous body image issues that arise. For me, they made a great effort to conceal my lumpectomy scar. Lumpectomy was, just that divot. They wrapped me up and taped me down tight. Mastectomy, I woke up and I looked down and I could see everything. And I was mortified, to be honest, because it wasn't the flat scar that I was hoping it would be. It was these empty, saggy, horrible-looking skin bags because they left the skin because they wouldn't have to stretch it out to the expansion process. They were stained blue from an agent called methylene blue that they used to map your sentinel node biopsy. In a way, I'm glad that they didn't conceal it from me because I would have taken weeks to look. I was not prepared for what was underneath the gauze. So people definitely should get counseling as they adapt to this new body. And it can certainly have many psychological effects. Because everything that's female about a female breast cancer patient is being arrested in this respect. And male breast cancer patients are, have a different set of concerns, obviously. But the female form is certainly changing during that process. In many cases, you're put into chemopause, which is a chemically induced menopause. So I highly encourage people to seek counseling during this phase. And most oncologists are ill-equipped to deliver that. So you definitely need to seek additional support outside of that circle because oncologists just aren't trained to deal with those kind of psycho-emotional issues that come about as a result of breast surgery. I'm glad you mentioned that. Thank you.
I have a few questions. If the margins are not clean, should a patient expect any type of resistance from her doctor? And if she does get that resistance, in many cases, what do you think about that? Go ahead.
So resistance as in to do additional surgery, as in a mastectomy as opposed to lumpectomy, or what kind of resistance are you talking about, Joe?
Thanks. If the margins aren't clean, I might think that either the patient or the doctor might say, well, there's no guarantee we're going to be able to remove all of the cancer. We can't even get clean margins, so maybe we shouldn't bother. Is that something that either the doctor is likely to say or the patient is likely to conclude?
It isn't, and simply because it would be unethical to leave malignant cells in a person where you know that you have unclean margins. That's the entire reason that I had additional surgery, because when they took the lump out, there was a side of the tumor that was all the way up until the edge of the sample. So they very clearly had additional tumor that they needed to remove. It wasn't an option for me. They said, we're going to do additional surgery to get clean margins. So I don't expect much resistance at all. I expect the doctor will press for more aggressive surgery, be it what we call a quadrant lumpectomy, which is taking a bigger section of the breast out, or in most cases, just go for the mastectomy. It really is easier to reconstruct a full breast than it is to reconstruct a half breast and try to make that look normal. So don't expect much resistance on that. And from a patient perspective, I don't expect much resistance from them not wanting the tumor to be removed to get that out of the body.
Okay. Is reconstruction a multi-step process, or does it happen all at once?
Great question. So there are a couple of different types of reconstruction that are both single step and multi-step. For the most part, earlier stage patients are offered multi-step reconstruction, and that's because they have more time. And also a longer reconstruction process lends a better result, a more natural looking breast, rather than just stuffing an implant into somebody's skin that has just been removed in the metastatic setting. So my reconstruction took, I had a mastectomy in February, and I went through the expansion process all throughout chemotherapy. So we went from having about 50 cc's of fluid in that expander bag that I told you about earlier, and then add 50 cc's at a time. I've got a very narrow chest wall, so that fluid would actually push backwards in my chest, and I couldn't breathe. So I had to go in a couple of times and have that fluid removed because I just couldn't handle that pain. And that was a really tough thing for me because I was so anxious to get a normal looking breast. I wanted something to fill out my clothes, and I couldn't handle the pain. So we had to go super, super slow, and we eventually stopped expanding in July. At that point, I had options. I could either have those little tubes pulled, a little cut on my side, and pull those tubes out, and it would actually seal itself off, and I could have a saline implant. That would be a permanent implant if I so choose. Saline is very hard. It's almost like a coconut shell. So it was not something I wanted to live with. I wanted to get what we call an implant exchange surgery. So they exchange that saline implant for a silicone implant, which is not harmful. It doesn't give you cancer or anything like that. It's a lot softer and feels a lot more like a natural breast. So that's about a 6-7 month reconstruction process. That's pretty typical in the early stage environment. In the metastatic setting, when you can convince a doctor to do breast surgery, they typically always do single-step reconstruction because they're not going to put you through 7 months of agony because it's really a quality of life issue in that respect. So they will actually go in and they will do immediate implant insertion. You don't have that muscle expanded, so you may have a little bit of contraction where that muscle is pulling back a little bit, and you're not going to have the symmetry that you would have had if you had gone through the expansion process. But they do offer both for different types of candidates, and typically the longer reconstruction methods with a better result.
What are the two types of diagnostic tests for HER2 positive?
So there's the FISH test and there's the FRG test. The FISH test is a lot less sensitive. It's kind of looking for the first line HER2 protein being present. Whenever that comes back negative, we really encourage doctors to go back and do that next step to make sure they're not missing those underlying HER2 receptors. There's actually a HER3, a HER4. There's a lot of different, HER, human growth protein presence, and there's a lot of great drugs that target that. If you don't know that you have it, you don't know that you need to get treatment for it. So it's really impeccable to get that information and push your doctor if you're not getting the cooperation that you need.
Thank you very much.
Thank you.
Kelly, I have one other question.
Mm-hmm.
Do you typically go through the reconstruction on the breast during chemo or after? When do you typically do that?
So it really depends on whether you're doing neoadjuvant or adjuvant chemotherapy. So whether you're having surgery before or after chemotherapy. Generally, you will not be able to get reconstruction when you're undergoing active chemo. You won't heal. Simply put, your body will not heal because your white blood cells and your platelets are being so depleted by the chemotherapy. It's just not something that would happen over a long period of time. So for me, they waited until about 2 months after I was done with chemotherapy before they attempted to do the implant exchange surgery. But only in an emergency situation will they do surgery on somebody who's undergoing chemo. It's just not something that they want to risk the infection risk or the open wound situation where they have to actually stop treatment.
Okay, thank you.
Thank you. Any other questions? All right. Well, thank you guys so much for your time, and we'll catch you next time around. Have a great night.
Thank you. Good night.
Good night.
Good night.